everyone. The Coordinating Center for the National Drug Early Warning System, sponsored by the National Institute on Drug Abuse, welcomes you to this, our 11th NDEWS Presents webinar. The NDEWS PI is Dr. Eric Wish, and our NIDA project scientist is Moira O'Brien, and I believe that both of them are in the audience with us today. My name is Erin Artigiani, and Barbara Kerr, Marwa Al-Nasir, and I will be the facilitators for this webinar. We are part of the NDEWS Coordinating Center team. For those who are interested, you can find detailed information about NDEWS, recording of prior webinars, and invitations to our upcoming webinars on our website at www.ndews.org. You will also find instructions for how to join our NDEWS network and participate in ongoing discussions with more than 1,600 experts and concerned citizens from across the United States and many other countries. We developed the NDEWS Presents webinars to work with leading substance abuse experts to explore emerging drugs and timely drug-related topics. This month, we are highlighting an innovative research methodology developed through NDEWS called the HotSpot study. Our first HotSpot study was conducted in New Hampshire in response to the increase in fentanyl-related overdoses occurring there over the past couple years. This afternoon, we are very fortunate to be joined by two researchers who have recently completed studies in New Hampshire, and they are Dr. Marcella Sorg, Director of the Rural Drug and Alcohol Research Program at the Margaret Chase Smith Policy Center at the University of Maine, and Dr. Lisa Marsch, Director of the Dartmouth Center for Technology and Behavioral Health and the Northeast Node for the National Drug Abuse Treatment Clinical Trials Network at Dartmouth College. The webinar will be approximately 90 minutes long, and we encourage you to submit questions during and after the presentations. Please post your questions in writing in the Q&A box. Don't try to use the raise hand feature. We want you to write in your questions, and we will hold a brief Q&A session after each of our presenters have completed their presentations. Our panelists and I will do our best to get to all of your questions, but if we don't, if necessary, we can also post a transcript of the Q&A with responses to all of your questions on ndews.org after the webinar, along with a complete recording of the webinar and copies of the slides from each of the presenters. So thank you again for joining us today, and I hope you enjoy our webinar. And I'm going to start things off today by switching over to my presentation, because I just want to give you a brief overview of NDEWS to get things started before I pass things off to my colleagues. So my name again is Erin Artigiani, and I am presenting today just to give a brief overview in the National Drug Early Warning System, which is a 5-year program funded by a cooperative agreement from the National Institutes of Health, NIDA, and the funding was received to support the Coordinating Center, which is housed here at the Center for Substance Abuse Research, CESAR, at the University of Maryland College Park. NDEWS is a national public health surveillance system that was designed to focus on these two things: to generate critically needed information about drugs and their public health consequences, and to leverage resources and collaborations to harmonize approaches to analyzing and presenting data. And it is our hope that the information that we and our colleagues are pulling together and sharing through the network and other resources will be used by local drug experts and policymakers to affect public health in their communities. So this is NDEWS and our components, and basically it involves people in a couple of different groups and a number of different tasks that we engage in to detect and monitor emerging drugs and changing drug trends, and then follow up on some of the things we find. So our people are crucially important to this process, and they include our scientific advisory group, which is made up of about 20 or so representatives from a combination of federal and non-federal agencies representing policy, law enforcement, public health, and academic institutions, and also, of course, our NDEWS network, which I mentioned earlier, and our Sentinel community site epidemiologists and our other epidemiologists based in communities across the United States. So today, we're really going to be focusing in on the following up part, because that's where the HotSpot studies come in. And our first HotSpot was done, as I mentioned, in New Hampshire, and we do a HotSpot study when we detect an acute or emerging problem that has the potential to spread to new users or new geographic areas, with the purpose of expanding the understanding of a particular regional or local drug trend, and also working with local experts and policymakers to support any efforts they may already have underway to address what's going on in their area. So we always start out by reviewing available data and research to get a sense of what's going on and who's involved and who would be the best and most active people to work with and collaborate with and coordinate our efforts with. And then we work closely with these experts to identify particular research questions or methodologies that might be most appropriate or most valuable to them. And we get them information that they may not already have, but they need in order to continue to address what's going on. And with that, we work with those folks to conduct focused research in the hotspot that could lead to an intervention to improve public health, and generally involves multiple types of methodologies. And so why New Hampshire in particular? How did we get there? Well, we saw clear evidence of an outbreak and a growing problem with fentanyl-related overdoses, which you can see in this graphic here, which shows that fentanyl-related deaths in New Hampshire more than doubled from 2014 to 2016. We also saw that New Hampshire already had a good effort in place and a number of local groups meeting and talking regularly about available data. And so we had local collaborators who were committed to learning more about their situation, like Dr. Sorg and Dr. Marsch, and had a willingness to work with us to be the first NDEWS hotspot and to pursue some additional information and deeper understanding of what was going on. So what we actually did in New Hampshire involved a two-phase study. We started out with our first phase, which involved reviewing the available data and conducting a site visit and identifying core contacts to work with. And we convened the planning committee in May, conducted the site visit in June, and released our first report in October, which is available in our website. So our first phase, our traditional hotspot, is a rapid study that we use to collect information and turn it around in a useful and user-friendly way. And then based on that initial research, there were a number of questions remaining, a number of other kinds of things that could be explored and done. And so that's why we then conducted 2 additional studies where we were able to support Dr. Sorg and Dr. Marsch and their local teams in order to go out and get a more comprehensive understanding of current users of fentanyl and the people who have died from fentanyl-related overdoses. So this is a selection of the reports, and I put this in here because I wanted to show you how we also do different kinds of reports. So on the one hand, what we have in the middle is a report that the Dartmouth researchers put together from their interviews with consumers and first responders and emergency department staff, which gives you a detailed overview of what they did and how they did it and what they learned and the implications of their research. But we also have a brief synthesis, which is the highlights report on the right of your screen, where we summarize the findings from both phases in all 3 studies that we did in New Hampshire. So I encourage you to go look at all of those. Again, they're on our website at www.ndews.org. And this is our general contact information in my email, and I'm happy to answer any questions you may have about what we did if you go and take a look at that. And so now I'm going to turn things over to Dr. Sorg, and so I'm going to stop sharing my screen so she can come in with her slides, and I'm pleased to introduce Dr. Marcella Sorg at the University of Maine, and she's going to speak about her analyses of fentanyl-related overdose deaths in New Hampshire that occurred in 2015 and 2016.
Okay, can you hear me?
Yes, we can.
Okay, great. So I'm going to be talking about our phase 2 study that we did in New Hampshire. And as Aaron showed you, our phase 1 study showed a very dramatic increase in fentanyl deaths, 1,629% increase since between 2013 and 2015. The objective of the phase 2 study was to look beyond the cause and manner of death to the details of the death events, including the decedent's interrelated medical history, social circumstances, toxicology, and autopsy findings. And we'll be going through the New Hampshire Medical Examiner context, explaining that to you a little bit, the data sets and methods we used, and then some of the results, the sociodemographics of the decedents, their toxicology and death event patterns, subpopulation characteristics, and a summary of our findings. The New Hampshire Medical Examiner System is part of the New Hampshire Department of Justice. It's a statewide system headquartered in New Hampshire where they do the case management and the autopsies. There are 2 forensic pathologists full-time at that office, and they certify the cause and manner and do all the autopsies. The local areas are covered by non-physician death investigators called Assistant Deputy Medical Examiners for short. It's ADME. And by and large, those are nurses, EMTs, paramedics who are working on a fee-for-service basis, and they're on call. The toxicology is done by a state lab for a few of the cases, and the large part of them are sent to the National Medical System Services Lab. Increasingly, they've been doing more of the cases with NMS. There are 2 kinds of overdose cases that they see, the examination and the autopsy. Examination is done by the ADME. There's no autopsy. This is the type of case they use for suspected overdoses that are more straightforward. In about 1/3 of the overdoses, though, the cause and manner are problematic, and they order an autopsy. The other exception to this is if the Attorney General's Overdose Task Force believes that there's a potential for prosecution, they will ask the medical examiner to do an autopsy. All of the overdoses receive an ADME death investigation and a comprehensive toxicology. For this study, we looked at all fentanyl deaths that were certified between January 2015 and September 2016. That was 541 cases. 505 had a complete file by the time we started our HotSpot investigation. These are cases where fentanyl is mentioned as a cause of death or a significant contributing factor. The vast majority of the cases, it was mentioned as a cause of death, and in a couple of cases, it was a significant contributing factor. We are looking primarily at the medical examiner's file, which includes the ADME report, the medical examiner's cause of death report, the autopsy report, and that's 189 cases, the toxicology report, which is all of the cases, and medical records when they are available. In addition, the Armed Forces Medical Examiner System did some urinalysis screening for us, looking at samples that had been retained from the autopsies that were done during the study period, and this was 136 cases. So the methods included identifying these deaths, and all of them had a location of death, a location of injury, and those data for 541 were sent to the University of Maryland Center for Geospatial Information Sciences. As I mentioned, 505 case files that were complete by October 1st were the primary analytical database for us. There were 189 autopsies, and 136 of those had the extra urine screens that were sent to the Armed Forces Medical Examiner System. I'll mention a few things from the spatial analysis. New Hampshire is a small rural state, about 1.3 million in population. Most people in the state live in the southeast quadrant, especially Hillsborough County, which is shown in the arrow there. There's also an interstate highway system, and you can see this pretty dramatic line up from the southern part of the southern states, hitting Nashua, Manchester, and Concord. And this area, Hillsborough County, and this urban southern eastern area is where most of the deaths occurred. Hillsborough County itself comprises 31% of New Hampshire's population, but 44% of the fentanyl deaths. It's important to remember that the Office of Chief Medical Examiner is investigating occurrent deaths. And I've shown a graphic here to demonstrate this. 96% of the sample is deaths that occur in the state of New Hampshire, and the decedent is a resident of the state of New Hampshire. About 4% of the sample are current non-residents. That is to say, deaths that occur in New Hampshire, the folks are from out of state. And then there's a third category, which are non-occurrent resident deaths. And this is an unknown number at this time until Vital Records locates all the resident deaths that may have occurred in other states. And those have been investigated by other jurisdictions. So what we're talking about is occurrent deaths and not non-occurrent resident deaths. Some key spatial relationships that showed up in the spatial analysis, and most of these were comparing residence location, fatal drug use location, sometimes called the injury location, and the death location. 4% of the state of the sample were out of state. The fatal drug use was more likely to occur in an urban area and areas with higher population density, and I'll show that in a minute. 70% of the fatal drug use occurred within 5 miles of an interstate highway. This is a pretty concentrated pattern. 69% of the fatal drug use, that's 61% of deaths, occurred at the decedent residence. Here's a map showing the population density, which is shown in the orange color scheme. The yellow dots are the deaths, and you can see that there's a cluster of the yellow dots in the southeast corner of the state. When you compare that to the Northwest, for example, it's dramatically different. This is a map of New Hampshire, and you can see the outline of New Hampshire here. The purple indicates the interstate highways, and the purple swath around those yellow lines is the 5-mile space that we were looking at in particular. And 70% of the drug use locations are concentrated within that band that's around the highways. I'd like to start talking about sociodemographic variables in terms of the population structure. You may not be able to see the tiny numbers here, but I think if you pay attention to the blue bars here, those are the ages of the fentanyl deaths. And you can see there's a mode of 29 and the mean is 36. The mean is higher than the mode because we have this little pocket of older decedents. The population of the state of New Hampshire, the census population of 2015, is much more flat. And so you can see that the decedents are distinct from the New Hampshire population as a whole. This is a table showing the age structure divided into male and female. Here's the male column and the female column. I'd like to draw your attention to the fact that only 1% are below the age of 20. And if you look at the younger population, that is to say anyone under the age of 40, that's 2/3 of the decedents. The other interesting fact is that the males total 78% of the decedents, so they outnumber females more than 2 to 1. We did ask Vital Records in New Hampshire to tell us about the education status and veteran status. They were working from a database of fentanyl and heroin deaths. What they found was that 61% of the decedents had a high school diploma or GED. That compares to 92% of the state census population. Veterans, 4% of the decedents were veterans compared to 10% of the state census population. So again, this population of decedents is distinct. Information from the ADME reports allows us to say that at least 20% lived alone and 5% were homeless. Moving along to the medical history, autopsy, and tox data. The autopsy revealed several conditions that would potentially increase mortality risk. In other words, the folks that get autopsies have additional problems, which is one of the reasons they end up having an autopsy. 60% with cardiovascular disease. These are pre-existing. 49% with liver disease and 20% with lung disease. Another risk factor is the fact that, as the ADME report tells us, 5% of these folks were recently released from jail or prison. What that means is that they probably were abstinent while they were incarcerated, and when they come out, they're no longer opioid tolerant and can more easily die with a lower dose of opioids. The same thing is true of a recent release from substance abuse treatment, which was at least 3% of the decedents. The reason I keep saying at least whatever the number is because the ADME report is a qualitative data report. It isn't a tight survey. The ADMEs are very good observers, and they mention the things that they think are relevant. They're filling in a form which has them review certain characteristics, but they are mentioning the characteristics that seem salient to them in their investigation. At least 63% of the cases had a history of opioid abuse. 13% with a previous overdose, 90% injection drug user, and 82% were heroin. 7% combination of heroin and pills, and 5% pills alone. 15% of our decedent population had had an opioid prescription during the last 12 months before they died. 10% had a history of chronic pain. Again, these are minimum numbers. And 21% had a history of mental health treatment. The most important takeaway from the toxicology analysis is that these folks were taking a lot of drugs. Now, some of the drugs may have been over the counter or prescribed legitimately, but a lot of them are taken recreationally or as part of their drug problem. In the medical examiner office, it is a requirement to do at least 2 tests. It's a forensic requirement to do at least a screening and a confirmation test for every drug that you end up mentioning on the death certificate. So it's a higher bar than just doing a screening. When we look at the toxicology findings, there are 114 drugs, and that is the substances that appear on the toxicology report. That includes what we call parent drugs, that is to say the drug that they took, and metabolites, that is to say the chemical that parent drugs change into in the body's physiology. Fentanyl and fentanyl analogs were the only drugs found in a few cases, but that was only 10% of the toxicology reports. In 90% of the cases, there were there was more than just fentanyl there. And in contrast to the death certificate, which in 57% of the cases listed only fentanyl. The frequency of the parent drugs that we found across the decedents averaged over 6 drugs per decedent, with a very large range. Some had 1, and one person had 19. One interesting fact about the fentanyl toxicology is that it kind of doesn't matter what level you take. The range is 0.75 nanograms per milliliter to 113. And that was what was found in testing the levels. The average is about 10 nanograms per milliliter. And having co-intoxicants on board, that is to say other drugs that might be synergistically boosting the opioid effect, doesn't seem to make much difference with that range. We looked at cases where fentanyl was the only drug found in toxicology. There were 48 of those, and the range was 2.7 to 36. We looked at cases where fentanyl and one or more other key co-intoxicant were present, and that range was 0.75 to 113. These ranges are not different. The range and standard deviation and mean are not different using a t-test. So it doesn't matter. The range is not different if you have co-intoxicants on board. The urine screens were a handy way to do a quick survey of the drugs present in a population. We're looking at urine screens that were sampled at the autopsies. The N is 136. These were sent to the Armed Forces Medical Examiner System. And this is the range of drug categories that were identified. And you can see that marijuana, for example, was found in 38% of those urine screens, antidepressants in 24, benzodiazepines in 28, and so forth. Another way to look at those urine screen drug categories is to look for combined, and you can see that there were many different categories that could be combined from 1 to 5 categories you might find in just one decedent. And the average was that there were almost 3 drug categories found per decedent amongst this autopsy population. Going to talk some about the death event and what we have found about that. The first thing is not a surprise. We did find that on Friday and Saturday, that was when most of the deaths occurred compared to the other days of the week. 70% of the drug use, the fatal drug use, happened at the person's residence. And you can see that that's the red color. And the green color is another residence, so not the decedent's, but still a resident location. And the rest is other locations like the street or some public space, for example. 2% were unknown. That's different from the place of death. And you can see that the numbers are not that different. In the previous one, we have 70% occurring at the residence, and in the place of death, 61% at the residence. So most of those, most of the drug use results in death at the residence. 17% get taken to the hospital or ER and die there. That's not very many, so just 17%. The difference between the residence location and the fatal drug location was interesting to us. If they were different, they mapped these with a green line. So you can see the green lines traveling from a residence to a location of the fatal drug use. Notice at the bottom here that a lot of these green lines are coming from out of state. But also, I think it's important to see the number of people who are traveling fairly long distances to take drugs. This is a close-up of Manchester right here. What we find from the ADME reports regarding the death event is that 63% of them were alone when they took the fatal overdose. 14% had a witness. Most were alone when they died. And in most of the cases, 92%, they called 911, but only 62% of the cases did EMS respond. That's probably because the person was already dead. And as I mentioned, 17% died in the hospital. According to the ADME reports, 12% had naloxone administered at the scene, and we find that 17% had a naloxone positive toxicology. We did rule out buprenorphine cases where they were taking buprenorphine. So some of these folks got naloxone at the emergency room or in the ambulance on the way. Okay, briefly, I'm going to go through some significant differences we found with subpopulations. The females are more likely to have an EMS response, a naloxone in their toxicology, and an opioid prescription in the last 12 months before they died. Older versus younger, that was a big subcategory. Those who are 40 and above are very different. They're more likely to have had an opioid prescription. They are more likely to have history of chronic pain, to be living alone, to be residing in a rural area. And they are less likely to have a history of opioid abuse, and less likely, and this is important, to get an EMS response. In terms of the folks with an opioid abuse profile, 9% had a history of chronic pain, 16% had a prescription in the last 12 months, 32% were unemployed, 8% disabled, 4% were homeless. And those, again, who had a history of opioid abuse were less likely to be alone when they died, more likely to have an EMS response, and more likely to have had a previous overdose or been released from custody. Those with a history of chronic pain, 38% of them had a mental health diagnosis, 8% were homeless, and 25% disabled. Those are higher. Significantly more likely to be over 40 years old and to have a prescription and also be taking something in toxicology. So the conclusions for the study were that this is a sociodemographically distinct population, more males. It's bunched around the age of 30 with another smaller peak in the late 40s, fewer high school graduates. The toxicology revealed that fentanyl eclipses other risks due to other drugs on board or other risk factors. Most people die before reaching the emergency room. There is polydrug complexity with an average of 2.88 key drug categories per autopsy decedent and 6.23 categories per decedent generally. And it's a heterogeneous decedent population with significant differences between males and females, older and younger users, and rural and metropolitan locations. I'd like to acknowledge my team here, Kathleen Stewart, Jamie Wren, Thomas Mitchell, the New Hampshire OCME, all of the folks there, particularly Tom Andrew and Kim Fallon and Janine Fedrick, Daniel Pelletier, Sue Watkins, Kimberly Hine at the Armed Forces Medical Examiner System, and the NDEWS staff. Thank you.
All right, thank you very much, Dr. Sorg. I think that was a great presentation, and you certainly shared a lot of information and data. We did get just a few questions. Looks like we have about 5. So the first question we have is from a viewer who had noticed that when you were talking about people's backgrounds, the background of the decedents, you mentioned most not having RX opioids or chronic pain prior, and wonders if that argues against the chronic pain overprescribing being a chief source of this kind of problem, and wondered if you feel that these people that you were studying are likely to be strictly substance abusing patients as opposed to chronic pain users.
I think it's a mistake to categorize them as one thing. And that's, I think, one of the points of our research is that we found it was heterogeneous. So in fact, we do have some with a history of chronic pain, and we have another subpopulation without. So I think it's important to recognize that heterogeneity. The second thing is that the ADME reports are a minimal count. They don't always know about all of the history, medical history that a decedent has, and so it's a minimum percent.
All right, thank you. Just a reminder to our viewers, please don't raise your hand. I need you to go ahead and submit your question in writing through the Q&A box so that I can share it with our presenters. And so we had a couple people who brought up questions about alcohol. The first one was from somebody who wanted to know if alcohol was looked at in the urine screen. And I can say, at least in terms of the screen used by AFMES, the Armed Forces Medical Examiner System, the answer is no, it was not included in that screen. But I don't know, Dr. Sorg, if you wanted to add anything about what the medical examiner looks at or how, or do they look at alcohol, for instance, as a co-intoxicant?
Yes, and in one of our graphs, I don't remember exactly which one right now, but alcohol is one of the main key co-intoxicants. And the research does show that it acts synergistically with opioids in toxicology. So yes, alcohol, we paid attention to that, and it is listed as one of the key drug categories in our study.
Okay, thank you. And another viewer asked, why is there a gap between the 90% of calls to 911 and the EMS response rate? And also wonders why this would be different for males and females, or older versus younger people, as you were quoting. I don't know if you have any theories.
I can't answer the last two. I don't know exactly why it's different for those subclasses, but I can tell you that when someone calls 911 frequently, it's because someone is already dead. And so the EMS may not respond in those cases. They may suggest that they call the funeral home.
Okay, thank you. And another person asks if you looked at all at the race or ethnic background percentages on the decedents?
Yes, 95% roughly of the state of New Hampshire is white, and our decedents are the same percentage, roughly.
And we had another participant who notes that when people die alone at their residence, they're often found in the bathroom. And so she wonders if you had any information about any one room in the house where people tended to be found more than others.
No, I think it would be possible to get that information if we looked at the ADME reports from that perspective, but we didn't do that.
Okay. Our next question is from somebody who wants to know if the tox results show the numbers of decedents positive for methadone, buprenorphine, or Suboxone.
Yes.
Okay, so that'll be something they can maybe
Yes.
look at in your report on the website. Or
It's complicated, but yes.
yeah. Okay.
Suboxone is actually, you have to look for two different substances, and you know, the methadone we usually find as the metabolite.
All right, another person asks, mentions that the absence of dose correlate to overdose is curious and wonders what you think might explain the fact that you saw many low dose related deaths.
Low dose of fentanyl is because it's just so darn strong, and the concentration is not only terribly strong, but it's unknown. With the non-pharmaceutical fentanyl, this is manufactured non-pharmaceutically out of the country, and it's a white powder. You don't know how much you're taking. Even when you think you're taking a tiny amount, it can be significant.
Okay, and then there was another participant who was hoping you might have some additional information about co-intoxicants found in the decedents, and if by chance you had a table or anything in your report where you talked about that.
Yes, it's in there.
Okay, so again, that would be something to go to NDEWS.org and pull up the full report. You might be able to find something useful in there. And let's see, and there's just a couple more questions here. Some of you guys are asking like really great research questions that just were not a part of the current studies, so I will get back to you on those. Let's see, here's a question here. Does your overdose data break down those who injected versus those who snorted the drug responsible for the overdose?
We know whether they have a history of injection drug use, and sometimes we can tell that they have injected if we find the syringe, you know, still sticking in them, or if we find paraphernalia at the scene. But we don't really know when we look at a toxicology whether it came by injection, and we don't always see the signs in a body that comes in for autopsy. You can't always see it, but in general, the best way to tell that is what is their history? Do they have a history of injection drug use? And in many cases, we also find the signs that that's how they took it. You also have to remember that the drugs that may end up killing them may not have been taken at that ultimate event. They may have taken drugs earlier a different way. They could have taken a pill an hour before. It's a very complicated thing. You don't know exactly how they took the drugs that you're finding in the body.
Okay, thank you very much. And another one of our participants asked, did you look for NSO/IMF as well as fentanyl?
No.
No, okay.
I don't know whether NMS looks for that. I don't know what that is.
Okay. So another one of our participants asked if you can talk at all about the reduction in heroin overdose deaths, and because this viewer says that it appears that they are decreasing and wonders if there is any concern that fentanyl has supplanted that drug.
There is a fear of that. However, I can tell you that there's more heroin out there than it looks like there is from the overdose deaths. People die from the fentanyl. They don't tend to die as often from heroin. And so the numbers are not a good proxy for how much use is out there. Certainly fentanyl use has increased, and certainly heroin use has decreased, but we can't generalize from the decedents what the use is. Dr. Marsch is going to have to address that issue really in terms of the proportion being used.
Okay, thank you. And just a couple last questions here. One is, were you able to secure any drug along with the decedent to determine relationship to the polydrugs found? People seem to
they always collect all of the prescription drugs at the scene. and do an inventory. And so we look at that. New Hampshire does not have a functioning prescription monitoring program yet that would be helpful for the medical examiner. The medical examiner doesn't have access to those data. So in fact, all we have is the medical history that we can get and the prescriptions on the scene.
Okay, and one final question here. Given all of this, what from your perspective should those of us in prevention be working on?
Yeah, I think the main thing is that this is very complicated.
Yeah.
Is that it's not a one-shot deal and not a one-size-fits-all. This population is heterogeneous, especially the older, younger, male, female, metro, rural kinds of discriminations. And so I would recommend that you target pretty carefully a wide range of groups.
Okay, well, thank you very much. I think we're going to move on now because we want to make sure that we allow plenty of time for Dr. Marsch's presentation, because I know you all will be very interested in her findings. And so I'm very pleased to introduce Dr. Lisa Marsch at Dartmouth College, and she's going to speak about her interviews now with fentanyl consumers, first responders, and emergency department personnel.
Okay. Hi, everyone. Can you hear me?
Yes, we can. Thank you.
Terrific. Well, thank you very much for the invitation to join this webinar. I'm going to be presenting on the portion of the HotSpot study that was conducted out of Dartmouth College. And we are very appreciative to the National Institute on Drug Abuse for the research funding for this and for the opportunity to partner with the National Drug Early Warning System on this work. And I have to acknowledge we had an outstanding team of folks here at Dartmouth College through our Northeast node of the National Drug Abuse Treatment and Clinical Trials Network that NIDA funds that conducted this research that I'll describe to you today. And I'm actually sitting in a room with them right now, and I just want to acknowledge that great appreciation for all the hard work that this team did. So as you've heard, and Erin gave a brief overview of this, New Hampshire has the highest rate of fentanyl-related overdose deaths per capita relative to any other state in the U.S. And you saw some data from Erin as well, and reproduced here that rate has doubled, roughly doubled in the past couple of years, and increased over 1,600% in the past 5 years. And fentanyl, as we've been talking about on this webinar, is an opioid that's incredibly potent. It's about 50 to 100 times more potent than heroin. So this graph shows the top 10 states with the highest fentanyl-related overdose deaths. And you see here that New Hampshire's #1. So the rate in 2014 is listed here, 12.4 deaths per 100,000 inhabitants. That increased dramatically, almost 100% change by the next year, 24.1 overdose deaths from fentanyl out of 100,000 inhabitants. And this is higher than any of these other states here listed in the top 10. #2 is Massachusetts, but New Hampshire is much greater overall than many of its nearby states. So the very first phase of our project was the phase 1 rapid hotspot study. And this was designed to examine the factors that give rise to this disproportionately high rate of opioid overdose deaths that we see in the state of New Hampshire. So for this phase, we engaged over 45 key stakeholders in the state of New Hampshire, and the folks range from treatment providers to medical responders to law enforcement to state authorities to policymakers. And we really sought their input and their perspective on what was happening in our communities. And it was clear that these folks were observing a marked increase in opioid overdose deaths, a dramatic spike in emergency department visits for overdoses, increased treatment admission rates for heroin and fentanyl and other opioids, but primarily heroin and fentanyl. And we also saw reports of increased seizures of fentanyl, and more so than heroin. It was at that point about twice the amount as heroin. And we did see some regional differences. We saw that use was reportedly higher in certain counties, particularly Hillsborough and Stratford counties. So for example, if you look at your toxicology data of folks in opioid addiction treatment, we saw that about 90% in Hillsborough County were positive for fentanyl compared to a much smaller percent, only about 5% in Grafton County, which is in the Lebanon, New Hampshire area. So we saw some pretty marked differences across counties in the state. And there was some confusion and sort of mixed opinions about whether or not consumers were actively seeking out fentanyl. So there were questions about, was this a drug that consumers were actively seeking to use, or were they unintentionally getting it when they were seeking out heroin? Was the fentanyl mixed with the heroin? And as part of this phase 1, although the data were incredibly rich and valuable, we didn't have any input from users at this point. And it was really clear from this phase of the work that what was needed was the voice of the consumer, and really to better understand what was happening in the communities from the consumer perspective, and also the first responders perspective on issues such as trafficking and fentanyl-seeking behavior and availability of treatment and prevention resources, for example, in order to develop the most empirically informed policy and community response. So this is what triggered phase 2, and phase 2 was comprised of both qualitative interviews and surveys from 6 different New Hampshire counties, and you see here on the map the 6 counties in which we conducted this phase 2 research. And we recruited both 76 active or recent opioid users in these counties, with somewhat heavier recruitment in Hillsborough and Stratford counties. We also recruited 18 first responders, and those ranged from folks in police, fire, and emergency medical services. And then we also had the opportunity to engage emergency department clinical staff. And so we conducted qualitative interviews and also some systematic survey research with these different stakeholders. And we did this quite quickly. The goal here was to do this, to have some rapid learning about what was happening in the community and look at the confluence of factors giving rise to what we're seeing in the state of New Hampshire from these different perspectives, from these different stakeholders. So this whole project was completed in 6 months, spanning from October of 2016 to March of 2017. And these are the primary themes that we focused on in this phase 2 rapid epidemiological study. So, and I'll briefly summarize the results from each of these in the subsequent slides. So we looked at the trafficking of opioid use, we looked at a supply chain, we looked at the formulations of the drug being used of heroin and fentanyl, we looked at fentanyl-seeking behaviors, we looked at people's experiences with overdoses as well as with naloxone, the opioid reversal drug. We looked at availability and perspectives on harm reduction, experiences with treatment and prevention, laws and policies, and then really sought to integrate the learning across all these different categories to understand what was giving rise to this markedly high rate of fentanyl overdoses that we're seeing in our state of New Hampshire. So just briefly to give you a little bit of information about the participants, this graph summarizes a bit about the characteristics of the consumers in our sample, our 76 consumers. And as you see, they were roughly about half male and half female, generally in their early to mid 30s, consistent with the demographics of the New Hampshire community. They were heavily white and non-Hispanic. And these data are somewhat similar to what Marcy presented in terms of level of education and employment. And here are the characteristics of our responders. Again, we had 3 categories: fire, police, and emergency medical service providers. Heavily male folks that responded, and also in their young 40s or so, early to mid 40s, white, largely white and non-Hispanic, and roughly about 17 to 18 years in their job. And here at the bottom, you see the average number of responses that they made to overdoses and average number of times that they've given Narcan, which is, again, this naloxone overdose reversal medication. These are the averages, but we know that in all 3 of these categories, responders reported giving as much as 1,000 doses of this overdose reversal drug. And then we have here the profile of our emergency department participants. These included medical directors, physicians, physician assistants, and nurses. Slight majority male, early 40s, similar race, ethnicity characteristics as our other samples. And again, quite a bit of experience with responding to opioid overdoses and giving Narcan in response to overdoses. And on average, these folks in our sample had just under 8 years in their position. So in terms of results, first, in terms of trafficking and supply chain, we had users report that fentanyl hit the market in New Hampshire in a pretty substantial way just about 2 to 2.5 years ago, at a time that heroin reportedly became somewhat less accessible. And reportedly, these drugs are originating in China but coming into the US via Mexico. And we know that many reported that they were getting access to fentanyl via Massachusetts, so that a lot of what's coming into New Hampshire is coming in on the Massachusetts border. And given the potency of fentanyl, which we've heard about today, individuals can transport smaller quantities of fentanyl than heroin, so there's less, it's less likely that people get detected when transporting fentanyl, so it makes it easier to avoid detection, but also it's significantly less expensive than heroin on the streets and much more potent. So it seems like there's quite a significant economic advantage of fentanyl in the communities. In terms of the trajectory of opioid use, we found that many individuals reported early exposure to substances in general, early recreational substance use, and also many reported a history of injuries or surgeries or chronic pain resulting in opioid prescriptions. And we also heard about a lot of intergenerational use as well as self-medication, largely for mental health conditions. So what you see in this graph here is the, in the bar, the mean age at which individuals first used prescription opioids, first used heroin, and first used fentanyl. And on average, we see at about age 21 years or so, folks reported that was their introduction to prescription opioids. On average, around age 24, we see reports of first use of heroin, and then about 4 years or so on average later, first use of fentanyl. The dots around the bars are the individual data points, so you can see the variability around these means. But it's an interesting path that we observed in a lot of our participants, and we saw that about 80% of our consumers in this study reported that their introduction to opioids was with a prescription opioid, and then that led to transition to heroin and heroin and fentanyl. So in terms of the formulation of the product and what people were actually getting on the street, there was some uncertainty. So responders sometimes had uncertainty about the composition of the drug. Consumers said there are certain ways to distinguish whether something is fentanyl or heroin or some combination, including the site, the taste, and surely the effect. What we hear is that the rate of onset of effects of fentanyl is much faster than that of heroin, but the duration of the effect from fentanyl is actually shorter than the effect of heroin. And so this actually may lead to more frequent injection behavior with fentanyl compared to heroin because of its shorter onset and duration of rapid onset, but shorter duration of effects, which of course might increase people's risk for infections from more frequent drug injection. We know also that reportedly overdoses weren't limited to injection use. Some reported overdoses from inhalation. And in terms of fentanyl-seeking behavior, we had some interesting results about fentanyl-seeking behavior. So we surely had a number of consumers report that they're actively seeking out fentanyl, but we also have consumers who say they prefer heroin to fentanyl, and most, though, just report buying what's available, and often knowing that it could be fentanyl, it could be heroin and fentanyl combination, and that they're likely to get fentanyl-laced heroin if they're seeking out heroin. And we also hear that street OxyContin is reportedly a thing of the past. So in New Hampshire, what's really accessible heavily is fentanyl, and reportedly even more so than heroin these days. So in terms of experiences with overdoses, the majority of our consumer respondents reported either personally having overdosed one or more times in the past or witnessing overdoses. And there was very consistent agreement that fentanyl was the culprit of the increased rates, the spike we've seen in overdoses and overdose deaths in New Hampshire. And in part due to the potency, the mix and consistency, and user and experience with it, particularly among folks who had been, chronic heroin users, there was a lot of inexperience with the fentanyl product. We also know that fentanyl can be reportedly made in one's home as well. Some people reported mixing fentanyl product in blenders in their own home. So there's a lot of inconsistency in the actual product on the street and the potency of it. We also had some reports about differing perspectives on an overdose scene from responders at the scene. So when law enforcement come to the scene, they are asked to prioritize a focus on tracking down the source of the drug, while other first responders might be more focused on a caregiver role. And sometimes this can create, we understand, some pretty significant challenges in coordinating efforts at the scene of an overdose. And in terms of experiences with naloxone, one consistent theme that emerged was the challenge in getting access to it, that there continues to remain some significant barriers in access in New Hampshire. So high cost, fear of police, fear of stigmatization if you have naloxone on you, lack of knowledge of use of it, and fear of withdrawal triggered by naloxone. And so we had some mixed opinions among our diverse participants in this study about the value of naloxone and the benefit of making it available to the public. But it's of note that no unanticipated side effects were observed with naloxone. It really had its intended effect of reversing opioid overdoses. In terms of harm reduction, we had pretty unanimous support among our respondents for needle exchange in New Hampshire. And at the time we conducted the study, there wasn't a single needle exchange program in New Hampshire. That has since changed, that we have some limited access at this time. But we also had very clear, very overwhelming, clear messages about the strong support for wider availability of Suboxone medication-assisted treatment programs, the availability of that for consumers in the state. It was, we had unanimous agreement that consumers can't stop using opioids without help and without these types of treatment services, that services are very limited and very difficult to get access to. There are very lengthy wait lists, trouble navigating the system, challenges with having the right insurance and funding to pay for access to care, and many people reporting just sort of giving up on trying to get into treatment because of all these significant barriers to access. So there was a strong recommendation from our participants to increase access to medication treatment and more effective addiction counseling options. In terms of prevention, many of our participants highlighted the importance of early education, really educating, starting at a very young age. They say high school is too late. We need to educate our kids and provide prevention interventions before middle school, because, youth are seeing these in their communities, their families, their communities are being impacted by this, and we need to have lots of prevention interventions in place that are effective to mitigate risk. There was a priority focus on dismantling stigma and this intergenerational use that many of our consumers had reportedly experienced. Strong interest in new efforts to effectively manage pain and to mobilize communities as being part of the solution. In terms of laws and policies, which was another theme we examined, we found that consumers aren't very well informed, and there was still some concern about police. And even though consumers know that there are Good Samaritan laws in place and that they are supposed to be protected if they call about an overdose of someone, sometimes there was reluctance to call about an overdose because they were worried about police arriving and finding drug paraphernalia on the scene and how that might have implications for them. And then there was some thought that prescribing crackdowns might reduce opioid prescribing, but it would likely just mean an increase in heroin and fentanyl use. And prescription drug monitoring programs, although they reportedly were perceived to have some value, many found them burdensome. So in terms of the confluence of factors that we see in the state of New Hampshire that seem to be contributing to this pattern that we've been observing with this fentanyl and heroin crisis, first, I think it's really important to remember that the state of New Hampshire has consistently ranked in the top 10 states with the highest rates of drug use overall. So even before this phenomenon that we're seeing now, we've typically had fairly high rates of substance taking in the state of New Hampshire. We also have a history of prescribing of opioids in the state that exceeds the national averages. So if you look here at this table, New Hampshire has not only a history of prescribing long-acting and extended release formulations of opioids, higher rates relative to the national average, but also almost double the rate of prescribing of high-dose opioid prescriptions in the state relative to the national average. And as we know from what's been happening nationally, it's clear that the surge in opioid prescribing practices that we saw as a nation have contributed significantly to the market demand we've seen for heroin and fentanyl. We also know that, and you saw some of these data that Marcy presented, that particularly the southern part of the state, we have pretty high availability of this highly potent drug in the region. So there's this interstate access right on the border, very close proximity to the core of the supply chain. And all of this is happening in a context where, unfortunately, there remains limited access to substance use disorder treatment and prevention in the state. And we are pleased to see that this is changing, but this has been a reality in the New Hampshire community for some time. So here are some specifics of that. We saw that treatment admission rates per capita are lower in New Hampshire than both the national average and compared to all other New England states. We have the lowest per capita spending on substance use disorder treatment in all of New England, and we're second lowest in the nation on that. We have the lowest rate of Suboxone providers, these providers of the medication buprenorphine, which is a very effective part of treatment for substance use disorders. And we have the lowest rate of providers per capita in all of New England. And also just general lower spending rates on public health funding compared to the national average and surrounding states. So you see that here, the rate in New Hampshire funding per resident in public health funding compared to the national average and compared to some of our adjacent states. So the good news is we've got, as communities are responding to this, and there's been some extraordinary community response to this crisis, including an initiation of needle exchange programs, which were just launched this summer in New Hampshire. And that's just terrific because we know we've seen a spike in Hep C and many infections from limited access to clean drug paraphernalia. Although it is still the case that the needle exchange availability is quite limited and there's quite a need to expand that. We know that some of our respondents, for example, reportedly drove to Vermont or other states to get access to needle exchange programs when they were not accessible in the state of New Hampshire. As we know from the data and from other sources, we still have some challenges in the naloxone access and some opportunities for expanding access. And then some of our consumers cited the rural context here and some of the challenges in terms of economic opportunities and some of the nature of the social networks in some of these rural communities as contributing to what we're seeing in terms of these networks of opioid using populations. And some people cited, their limited access of things to do in some of these communities where you have this highly potent drug available. And interestingly, some people even cited the live free or die motto of the state of New Hampshire as potentially contributing to the substance taking that we see in the state. And unfortunately, in recent months, we've seen that carfentanil has emerged on the scene, and we've got 10 reported deaths so far from carfentanil, which is an opioid drug that is actually 100 times stronger than fentanyl. So it's extraordinarily strong, and even, a quantity that's like the size of a grain of sand could potentially be fatal. It's used as an elephant tranquilizer, as some may know. And so the reports as of July are that we've had 10 deaths in the state from that drug, particularly in the southern part of the state. So there are many clear implications, I think, from these data, including the significant need for more prevention efforts with youth and in their communities, and more effective treatment of options, and reducing barriers of access to treatment, and having some innovative points of entry into treatment systems, expanding treatment to include broader availability and affordability of effective medications, incentivizing more providers to become part of the solution and become buprenorphine waivered providers, and increase capacity for care for so many that are impacted by this opioid crisis. More focus on prudent opioid prescribing practices and best practices around that for not only prescribers and providers, but also for patient education around this. And I think there's also a really clear opportunity to provide more support to the many first responders who are tackling this crisis every day in our communities, and they're saving lives, and they are out there being exposed to some pretty traumatizing scenes. And I think that we need to ensure that we're giving the right support to our providers who are doing this on a daily basis. There's still, as we talked about, an opportunity to expand needle exchange for the state of New Hampshire to increase its dialogue and collaboration with the state of Massachusetts on addressing the trafficking we see and what's happening across the border. And then also, stigma is a huge issue, and fear around this issue. And there are so many different stakeholders involved in this that we could target, not only consumers, including tackling some of the issues we spoke about with naloxone and stigma of naloxone, and also concerns about the Good Samaritan law, but also physicians and pharmacists, and really underscoring the chronic relapsing nature of opioid addiction and how to view care models for opioid addiction in the context of a chronic disease management perspective, to highlight the value of naloxone and increasing options for care and reducing barriers to access to care in law enforcement communities, and really educating about how treatment can be effective, and that there are alternative approaches to punitive measures for folks struggling with this disease of addiction. And also the public about the risks of opioids, and particularly our youth, and how do we prevent future generations from experiencing the same phenomena that we're experiencing today, to break that intergenerational cycle of addiction. And then finally, I think we have a tremendous opportunity to extend our services beyond acute care. When people, for example, show up in the emergency department, they're offered, their acute needs are taken care of, and in terms of tackling overdoses, in terms of dealing with infections, for example. But there are tremendous opportunities for us to think about the emergency department or other acute care contexts as a place where we could have entry into treatment. We could make those new portals into continuing care models where people could get access to ongoing science-based care and recovery support services. So I'd like to acknowledge the outstanding team on this, not only the many men and women who gave their time and shared their experiences with us, and who participated in this study and just gave us such rich insights into what has been happening in their lives and in their communities, but also the outstanding research team here at Dartmouth that's part of our Northeast node of the National Drug Abuse Treatment Clinical Trials Network, and the partnership with NDEWS and the National Institute on Drug Abuse for the research support for this. And then finally, last slide, I just wanted to ensure for folks who may be interested in this, in this area, and also additional research that's happening in our New Hampshire communities. This is the website for our Northeast node of the Clinical Trials Network. It's a group not only of researchers at Dartmouth, but also many community partners in many different healthcare systems, and patient advocacy groups, and governmental partners around the states of New Hampshire and Vermont and Maine that are collectively identifying timely and significant research questions to study, but also to identify best practices that can be embedded in our communities and provide sustainable models of empirically supported resources that can help us in tackling the opioid crisis and other types of problematic substance use. So this website has a lot of information about many studies that we have the opportunity to engage in, including a lot of detail about this project, the NDEWS Phase 1 and Phase 2 study, but a lot of other resources in the state. And for folks who are interested, we would welcome your participation and collaboration as part of this node of this National Clinical Trials Network. And so we'll stop there. Thank you so much for your interest in this topic and for your interest in our research.
Okay, thank you very much, Dr. Marsch. That was a fantastic presentation, and we really appreciate all of the information you shared with everyone today. I want to chime in with a few additional thank yous of my own here as well. We want to make sure that we acknowledge all of the staff at AFMES who participated in the urinalysis results that Dr. Sorg mentioned earlier, including Dr. Jeff Waltersheed, Lieutenant Commander Pedro Ortiz, Major Lynn Wagner, and the rest of the team there, and also, of course, our NDEWS PI, Dr. Eric Wish, who led the analyses and the development of the tables and other information that was shared in the report. And of course, we all have to offer our hearty thanks to Moira O'Brien and the staff at NIDA, the National Institute on Drug Abuse, for supporting all of this research. And so I'm going to turn back to the Q&A now. And because we did have a number of questions come in while you were speaking. And the first here comes from a viewer who asks, when you look at the states, what is it about the Northeast that these rates seem to be higher here, that fentanyl is found there?
Yeah, it's a great question. You know, the Northeast is a hotspot region, but there are other parts of the country that have been heavily impacted by this as well. We know in the Kentucky, Ohio region, for example, and you may have seen what just emerged in the data last week in the state of Maryland. So, you know, we are experiencing a very high rate of overdoses from fentanyl in New England and particularly in New Hampshire, but we're surely not alone. I think there are many factors that could be giving rise to that, but it seems that part of it is access, and part of it, I think, the rural communities seem to be largely impacted by this, if you look nationally at the pockets that have been most impacted by this. But I think, unfortunately, if you look at the trajectory of what's evolving now, and as we continue to see fatalities from opioid overdoses increasing, we're seeing very similar trends in many communities and increasingly even in some, you know, more suburban and urban contexts. So this is a pretty significant issue for our whole nation and not just the New England community.
Okay, thank you very much. And we have another question from someone who asks if you looked at more socio-cultural factors that could be playing a role in the rising problem with fentanyl, particularly stigma against opioid use and the role that may play.
You know, I think that there is a terrific opportunity to actually have a more systematic examination of some of the sociocultural factors giving rise to this. And we definitely heard reports of, you know, changes in communities in terms of access to, you know, jobs and economic challenges in many of these communities. These communities may have been vibrant. Some of the communities most impacted by this may have been very vibrant communities several years ago, and many of the jobs have left. We see that there are some interesting dynamics in some of the social networks among opioid using communities that I think emerged in some of the dialogue that we had with consumers in this study. And if you read the detailed report that Erin showed us on the NDEWS website, we have such rich stories embedded in this report and qualitative data that touches on these themes. But I think it really has led us to think that there's an opportunity for a much more in-depth examination of some of these factors that are collectively giving rise to what we're seeing here.
Okay, thank you for that. We have a question here from a viewer who wants to know, are professional first responders concerned about conflicting goals of Good Samaritan laws as expressed in Ohio? Did you hear anything about the Good Samaritan laws in your interviews?
We surely heard about the Good Samaritan laws in our interviews here, and we, yes, I think that we heard, you know, reluctance from some consumers to to respond quickly when someone overdoses. In fact, some folks reported that they would try to sort of clean up the scene a little bit and hide drug product and paraphernalia before making the call, because even though they understand that the Good Samaritan law is supposed to protect folks who call for these types of events, that there's still a lot of personal concern about risk and sort of differing perspectives that police may have if they arrive on the scene. And particularly if the scene, we've heard some discussion about, some of these overdose scenes being treated as crime scenes and scenes where people are trying to investigate source of drug and try to understand how people are getting it and what they're using. And I think that really can potentially be risky, because I think it could further reduce people's likelihood to call and potentially save someone's life if they're worried about these types of consequences, including potential criminal consequences.
Okay, and we also have a question from another viewer from New Hampshire who was wondering if you had any more specific information about what the respondents were saying about challenges to obtaining Narcan. I know you have more of that information in your full report, but I don't know if there's anything else you'd like to share today.
Yeah, I think that what we heard, and some of our team here I'm sitting in the room with our team, they may want to chime in on this, but what we heard is that sometimes people had difficulty getting access to it for themselves. And I know that we've even heard that some of the first responders have run out and have supply periodically because they've had to use such high doses to reverse a fentanyl overdose. But would anyone in the group here like to comment to that? I'll just invite our team here to respond to that.
Hi, this is Bethany. So I was also a member of the team that conducted some of the research and the interviews. And I think from the experience that we've had asking questions about access to naloxone, I think what we found is that preliminarily anyways, that it's really a regional problem. Folks down in the lower part of the state in Hillsborough County don't seem to have as much of a problem because they know exactly where they can go to get it. There is the Safe Station program, which is right there to help them when they need it. And then there's also more access to pharmacies and programs that are set up to help with this problem because it is so pervasive down there. But in some of these other states, counties in the state, Grafton and Sullivan County, where there is still a big problem per capita, folks reported not knowing where to go to get naloxone, and reported that they understand that it is expensive, but they don't know how expensive. And maybe they could go to the health center in Newport to get it, but that means I have to get in my car, and I don't have my car, and I don't have gas to get to Newport. And it really was more of a non-issue for them because they didn't have as clear access to the medication.
All right, thank you, Bethany. Now we have a question from someone who wonders if the state of New Hampshire has implemented any Pure Run services anywhere, like for instance, in the emergency room.
Pure Run services, is that what you said?
That's what I said. Yeah, that's what was in the question. I don't know if you have any information on that.
Would anyone like to comment on that?
Yeah, so this is Bethany again. I think in the interviews that we conducted with the responders, a lot of the hospitals, I think most of the hospitals that we talked to do have either a referral to a peer recovery specialist or somebody that they can potentially even have on staff who's there to serve in that purpose, so that when somebody does come into the ER with an overdose, they have the option to speak to a peer recovery specialist to weigh their options for treatment and then get the resources that they need to potentially get into it. That access is much more limited in some of the smaller counties like Sullivan and Grafton, both of which the hospitals have just recently initiated those kinds of practices with a peer recovery specialist. So a lot of that is new, but from what we heard, the hospitals and the emergency departments are doing their best to utilize that kind of service.
Sorry. So we have a few more questions, and I know we're getting tight on time, so I'm going to try to pick out a couple here to throw out. And one is from somebody who wants to know, and this could be either for you, Dr. Marsch, or you, Dr. Sorg, if there was a particular town in Hillsborough County that was affected the most by the overdoses.
I would say Manchester, but Manchester would be the main one. Yeah.
Okay, thank you.
That's, Erin, that's consistent with what we saw in our data as well.
Okay. Let's see. Somebody else said that mentioned Hillsborough as well and says that they found it amazing that Hillsborough had 90% fentanyl while 5% in Grafton County, and wonders if there's any possible explanation about why there would be such a difference between those two parts of the state.
So the data that you're referencing were from urine samples from folks in addiction treatment systems in those two communities, and it is a marked difference, but I think it reflects the availability of the drug in those different contexts and what consumers are using in those communities.
Okay, and we have one question here from a viewer who noted that none of the police administered naloxone and wonders if there is a reluctance on the part of law enforcement to use it, especially if they are on scene sooner than fire or EMS.
This is Bethany. So what we had heard both within the study and in doing our own research prior to the study, we spoke to the director of EMS services, and the police departments in the state of New Hampshire are not required to or licensed either to carry naloxone nor to administer it in the same way that the EMS services are. EMS responders are licensed to provide medications in the same way that, you know, at least in a limited format, the way that doctors would be. It is a medication that you need to have training in how to provide, but also from a medical standpoint in how to give somebody in that level of care. And the police departments in the state seem to be a bit more reluctant because from what we understand and know that is not their role. Their role when they come to a scene is to enforce the law, and therefore it muddies the water a bit to have them performing services that EMS is capable of and right there following them 2 seconds later to perform. Thanks.
Okay, and just one last question here from a viewer who asked, are folks typically making their own fentanyl locally, or are they getting it via spiking of large supplies from elsewhere, perhaps mostly out of state? I don't know if that's something either of you would like to address.
So we definitely heard reports of people getting access to active ingredients in fentanyl, but not the complete product, but then manufacturing the product in their homes. And in fact, this trend you see is consistent with some of the seizures we've seen in our communities, and including on the New Hampshire-Massachusetts border of various components of fentanyl that are being shipped still, it looks like, from China through Mexico, but you can literally manufacture the full product in one's home setting. It makes it a lot more difficult, of course, to think about interdiction efforts around it.
Okay, thank you. And so I just wanted to put up our contact information one more time here for everyone, just to remind you, our website is ndews.org, and you can find all of our reports there, including the highlights report that we've been talking about today. And I hope that you will agree with us that this research and these presentations and the conversation that they have generated does show that this hotspot type approach to doing research can be successful and can pull together a great deal of information from a variety of resources in a meaningful way. But of course, as with other research, there's still a lot of questions and a lot of things to talk about and think about. And we appreciate everyone's input today. And just want to let you know that we do have some additional webinars coming up. So please visit our website for that information. Our next webinar will be coming up later this month, and that is a part of our special series that we're we're working on with a colleague at the University of Auckland. And this is part 2 of a 4-part series examining global early warning systems. This one will feature special guests from Australia and New Zealand talking about efforts in that part of the world. And one last thing before you leave, we would really appreciate it if you would just take a couple minutes to do a quick poll for us and let us know how you felt about the webinar today and what topics you'd like to hear about in the future. So I have launched it, and if you'll just take a moment to mark off your answers, we would appreciate it. And once again, just to remind you, this full webinar, as well as the slides from each of our presenters, will be made available on the NDEWS website on the NDEWS Presents page. So in case you missed something, or there's something you want to go back and check, or you want to encourage a colleague to watch, you will certainly be able to do that. So again, thank you to all of you for participating, and thank you for submitting all of your questions. I know we didn't get to all of them today, but we certainly appreciated your opinions and the questions you shared, and you certainly gave us a lot to think about in terms of future research we may all engage in. So it looks like we're getting close here. Most of you have entered in your answers for us, so thank you again for doing that. So one last question that came in here. Oh, one other thing that I can share with you, we don't do any kind of continuing education credits for this, but we can send you an email so you have something in writing to show you participated, if that would be helpful to you. And also, now that we've done the New Hampshire hotspot, we are looking for additional sites and other locations to go to. So if there's anything you think after seeing these presentations today that we could help out with in your area, please get in touch with us and send an email to our NDEWS email or to my personal email, and we'd love to talk to you more about it offline. Okay, so I think that's about it. If there's still a few of you who want to jump in and complete the poll, you can certainly do that. But otherwise, thank you everyone for joining us. And we look forward to hearing from you all again at our next webinar.